Hi guys, welcome to week 2. This week we're going to be covering GI and endocrine disorders. Your first chapter is the one we're going to cover in this particular video. It is a long chapter, so I might be grazing over some of it. The PowerPoint does a really good job at presenting the main ideas, and of course read the chapter and just try to get through it. We are talking about, in chapter 33, we're talking about GI disorders, peptic ulcers, GERD, and vomiting, which is why it's so long, because those are it's a huge part of a lot of the medications that we dispense, such as Prilosec, Nexium, antacids, etc. So I'm not going to cover the process of digestion. I want you guys to cover that on your own. It's just a little review. Some of you may already be pretty familiar with it. We're going to start off right with the production of ulcers. And an ulcer is basically a damage in the lining of the stomach that can lead to bleeding. And over time, it can actually cause a lot of other problems. So peptic ulcers are open sores in the mucosal linings of the stomach and the duodenum. The most common cause is the bacteria H. pylori. However, there are other causes, which include excess gastric acid production, even when food isn't present in the stomach, insufficient mucus secretions, emotional stress, alcohol, and smoking, as well as certain drugs that are ulcerogenic. So, symptoms of an ulcer, of course, pain is going to be the main one, especially once somebody eats. Nauseousness, loss of appetite, and vomiting. Duodenal pain, which is just below the stomach, is usually relieved by food. Gastric pain is brought on by food. So over time, this ulcer, this erosion in the mucosal lining can lead to hemorrhage, hypotension, or shock. So we definitely want to manage that as quickly as possible. In addition, something similar is called gastroesophageal reflux, and instead of being in the stomach, it's actually in the esophagus. And it involves regurgitation of stomach acid right up into the esophagus, and the main symptoms are irritation and burning in the chest or throat, as well as pain. It occurs after meals and worsens when lying down. Sometimes lifestyle changes can help with GERD. Sometimes it does require surgery in order to fix the problem. And a lot of times what's wrong is that the esophageal sphincter that prevents that acid from coming back up is damaged, which over time can lead to, damage leading up the esophagus. So management of GERD includes lifestyle changes, eating smaller meals, eliminating certain foods, losing weight if you're overweight, and elevating the head of the bed when you're sleeping. So management of peptic ulcers as well as GERD, we're going to move into anti-secretory drugs. So our first one is H2 receptor antagonists, or H2 blockers, also called antihistamines. Histamine receptors are found in the gastric mucosa, and they mediate the secretion of gastric acid, which basically means they're the ones that are responsible for the secretion of gastric acid. So if we can block them with an antihistamine, we have essentially cut down on the amount of gastric acid in the stomach. They differ from histamine receptors that are involved in allergic responses. I believe those are H1 receptors, and we'll cover those at a different point in time. So, as antagonists, they block the histamine from the receptor site. Less acid is produced, and suppression of acid secretion is less than that with proton pump inhibitors, which we'll also cover in a second, because only the histamine receptor is blocked. Administration with these medications can be oral or parenteral. Absorption from the stomach, if given orally, is usually about 90 minutes for cimetidine and 2 to 3 hours for the other medications. And antacids can delay the absorption of cimetidine, so we just want to be careful with that interaction. Adverse effects of these medications generally include headache and constipation. And I've mentioned some names. You heard me say cimetidine. They all kind of sound familiar. Famotidine, ranitidine. They're all going to sound pretty familiar to each other, pretty comparative to each other, so alike. Let's see. They are recommended for the short-term treatment of benign gastric and duodenal ulcers, and they are also used in hypersecretory conditions where somebody's secreting too much gastric acid. These might include multiple endocrine adenomas or Zollinger-Ellison syndrome. Our next, and if you turn to page 547, it goes over the adverse effects, and the next page goes over the drug interactions. Good to become familiar with just the basics on those. That way you know what you're looking out for when you're giving a patient when you're giving a patient H2 blockers or antihistamines. Our next class of drug is the prostaglandins. So prostaglandins aren't used as often as H2 blockers or proton pump inhibitors. They have specific receptors in the gastric mucosa. Prostaglandins do, and these receptors mediate bicarbonate production in the mucosal barrier. So drugs such as NSAIDs inhibit prostaglandin synthesis, which is why they cut down on the amount of protective barrier between the mucosa and the gastric acid. Only one synthetic prostaglandin is used for use in NSAID and aspirin-induced ulcers, and this is covered on page 550. I'm going to stop for a minute and I'll pick back up in another video.